So now we're going to talk about myasthenia gravis. This is a motor disorder in which you see fluctuating localized skeletal muscle weakness and fatigue. It comes from an autoimmune disease that is acquired, and it affects the neurojunctional motor function and is often associated with a patient having an enlarged thymus gland or a thymoma, which is a growth of the thymus gland, although it is not always totally understood what that connection is. It can present as one of three serotypes. In the most common one that you will most often see, there is an acetylcholine receptor antibody that binds with the receptor sites where acetylcholine would be taken up to make the nerve impulse generate and transmit. And so therefore, because that is destroying the receptor site, acetylcholine can be only taken up by the ones that are not affected, thus reducing the conduction at the neurojunction site. There are two less common that make up 20% of the types that you may see, and they also interfere with the receptor sites in a little different ways, but essentially cause the same kind of symptoms. So this just kind of explains it a little further. With myasthenia gravis, acetylcholine cannot bind to the receptors, and because of that, you cannot get the transmission of the nerve impulse well. Patients can have will have a chronic autoimmune disease with this that does not go away. Again, you have an antibody that is produced against the acetylcholine receptors at the neurojunction. And so these receptor antibodies will destroy the sites, and the acetylcholine again cannot be taken up. And so it's considered a nerve impulse transmission defect at the synaptic junction that will be an ongoing issue for the patient. Myasthenia gravis has several clinical manifestations. They can be ocular, bulbar, or generalized presentations. They often will come in first to the doctor's office, just saying they have overall muscular weakness and fatigue, can't seem to move, walk, or stand or do things like they normally did before, which goes along with so many of these diseases that it makes it, once again, they have to go through a trial and error to kind of evaluate what muscular disease can it be. 2/3 of the patient will have ocular symptoms that affect the eyes. Ptosis can be one eye or the other. These drooping eyelids is what that is called. You may have patients that complain of diplopia, where the extraocular muscles become very weak and the patient will have double vision. These ocular symptoms often occur within the first 2 years of the disease starting, and symptoms worsen with activities where patients are having to use their eye muscles very frequently. So people in certain jobs where they're in the computer all the time, or they're reading all the time, or they're doing something with their eyes all the time, are going to be having more problems quicker and worsening faster. The second type of symptom is bulbar symptoms, and these are ones that affect pretty much the throat area. And so patients may have an altered voice, change in their voice. They may have nasal regurgitation. They may experience choking episodes off and on, and they don't know what's causing that. And they may have difficulty swallowing in a safe way. And this appears in about 16% of the patients. So it's a fair amount that this is affected by, and it's coming from the medulla of the brainstem, and its effect on the cranial nerves. The throat is really weakened, and they'll have problems with chewing, swallowing. They are high risk for aspiration precautions. Anytime you have family members who are attempting to feed these patients, you need to be very careful with newer diagnosed patients because they need a lot of education on little tiny, food consistency, little tiny bites, things to really watch for if they're able to swallow fully. So there's not something sitting there that's going to make them later aspirate as well. Many patients will progress to having situations where they get into respiratory collapse. There is an increase for myasthenia gravis patients in having rheumatoid arthritis, lupus, and thyrotoxicosis. And so there is some connection between those diseases, likely related to autoimmune deficiencies. So watch these two videos and you'll kind of see how this works. It's great examples, so I really want you to see those. Onset of muscle improvement when you give Tensilon IV to patients happens within 30 to 60 seconds, which is dramatic. They aren't able to function or speak or swallow or move very well, and then you give them this drug IV, and just within a few seconds you start seeing a complete change. And what edrophonium does, or Tensilon does, is it prevents the normal destruction that occurs of acetylcholine, and so it's making the patient have higher levels of circulating acetylcholine in the system, and therefore more chances for some of those to hit more of the receptors that have not been too damaged. It's not long lasting. It only lasts 4 to 5 minutes. But you can see a marked improvement. And that's a key test to know that this is myasthenia gravis, because if this works, that's it, you've got your diagnosis. So in being prepared to assist somebody with doing a Tensilon test, you must have atropine sulfate available, because this drug can also cause a refractory bradycardia, and you have to be prepared for it. So the other drugs that may be given are some of these that are listed, like mestinon or prostigmin. They are considered anticholinesterase and anti-myasthenics, and they work in different ways, but essentially they're kind of optimizing the neuromuscular impulse transmission by preventing the decrease of acetylcholine by the enzyme cholinesterase that really, is meant to be there to take up part of it. Another key point to know about these drugs is they have to be administered with food, and you want to assess patients for any drug interactions. So I would take and really do some research, at least on these two drugs, to look at what drugs might be likely to have interactions for a patient that's on these, just for your own knowledge. These are some of the things to be considered related to nursing management. These patients can become immunosuppressed depending on what medications they receive. Again, plasmapheresis may be used to remove circulating antibodies, as we've seen with a couple other diseases. They often are going to need respiratory support. Some patients may have repetitive nerve stimulations and electromyography, trying to map out where the things are affected, and from a treatment standpoint. We want to promote self-care guidelines with these patients. Again, with any of the other diseases that have affected CNS and or motor function, as well as, physical well-being and ability to do ADLs, we want to really optimize that as long as we can, and assist patients with communication. As with some of the other diseases, if you're having speech issues, you may need assistance there. Nutritional support and safe swallowing is twofold, because patients, not only we want to watch out for aspiration precautions, but patients also experience this a lot, and so they may just feel like, I don't feel like eating. I don't want to eat because I'm afraid I'll get choked or get sick. And so, often their nutritional intake is not adequate because of that. And then you have to be concerned about, how do you teach family members the best way to feed somebody? Small little bit bites, certain consistencies of food based on speech therapy input as to what's going to work the best for them. And then not, really make sure they have a really good understanding of how to safely, watch someone eating and be available when someone's eating for emergencies should those occur. With the eye issues, sometimes eye protection is recommended. And then sometimes, if the thought is something to do with the thymus gland is a contributing factor, then they may do a surgical thymectomy to see if that will have impacts in improving the condition by removing the thymus gland. Make yourself some notes side by side about these two crises that occur with myasthenia. There's myasthenia crisis, and then there's cholinergic crisis, two opposite ends of the spectrum. With myasthenia crisis, you have severe deficit of acetylcholine and severe muscle weakness, especially with the throat and respiratory. The patient may have trouble controlling secretions, saliva, mucus can get caught in the upper airway, and they can respiratory arrest. Obviously, quick treatment to give some Tensilon and putting them on some of this, on some way to kind of get it under control better, is going to increase the amount of circulating acetylcholine, so that's a good thing. And so that is why that is the treatment of choice, at least initially. On the opposite end of that, you can have cholinergic crisis. And this comes about when the therapy that you're on for myasthenia gravis get to a toxic level in your system. And so what happens with that is you have way too much acetylcholine at the junction, and you tend to see some of the same symptoms, but they're based on parasympathetic reactions, such as increased rest and digest. The person will be more lethargic and sleepy, and increased salivation. You may see some bronchoconstriction, increased sweating, and the patient may have bradycardia, for which, once again, you want to be prepared to have some atropine to reverse the situation and likely hold their myasthenia gravis meds until some decision is made as to what is the optimal time to restart that. The problem is, though, with both of these, you may have similar symptoms, and so put these down side by side so you can really kind of think about the differences. This is just a slide that kind of hits the main teaching points So be aware of those because they affect how well